All right, here we go. Hello, and thank you for watching this program on diagnosing radiculopathy. There's no audio taping or videotaping allowed, and any unauthorized reproduction, dispensing, forwarding, or copying of this target coding presentation is illegal. The information in this presentation is for educational purposes. It's not intended to be a substitute for your clinical decision making. We're going to be talking about clinical situations, so it's up to you to make your own thorough clinical decision making. This presentation should not be construed as any written policy for any organization or federal agency. It's not intended to be legal advice. Target coding does not engage in providing legal services. CPT is a registered trademark of the AMA, and every attempt has been made to make certain that the information in this presentation is 100% accurate. However, it's not guaranteed. Let me tell you a little bit about myself before we get going. My name is Dr. Marty Kotler. I am a chiropractor. I practiced for 16 years. And about 12 years ago, I started a company called Target Coding. I'm the president of the company. I'm certified in CPT coding. I'm a certified professional compliance officer. My areas of expertise include Medicare, HIPAA compliance, chiropractic record keeping, treatment plans, compliant cash plans, which is very important. I've been getting more and more doctors working with my company that are cash practices more than ever before. And a lot of people, consider me, the insurance coding guy. I'm not the insurance coding guy. I am the compliance guy. If you want to put a label on what I do, I'm all about compliance, making sure. Now, when we say the word compliance, there's many things that go under that label of compliance. There's billing compliance, there's coding compliance, there's documentation compliance, there's HIPAA compliance, and there's Medicare compliance. There's 5 items. So we specialize in those 5 items. I've written 10 training manuals on chiropractic record keeping, billing, and coding. Write articles for Chiropractic Economics, Dynamic Chiropractic, The American Chiropractor, the American Academy of Professional Coders monthly magazine, and for many state association newsletters throughout the country. I'm also a guest speaker at many state association conferences throughout the country. So those of you listening to this presentation, if you're part of your state association that's looking for a speaker on compliance, let us know. I typically can get a sponsor, so it works out very well. Okay, let's begin. Radiculopathy. What is it? Well, radiculopathy is caused by compression of the nerve as it exits the spinal column. So there's nerve root compression and irritation. When you have nerve root compression and irritation, what's going to happen? You're going to feel pain. Patients are going to come in with all different types of symptoms. Some patients just have numbness and no pain. Some patients just have tingling without numbness and pain. Some patients just have weakness in their arms and legs. In my practice and in most of my clients' practices, patients that come in with radiculopathy respond very well to chiropractic care. Patients get better very quickly. Now, radiculopathy, it could occur in any part of the spine, but the most common areas are lumbar and cervical. Now, what causes the nerve roots to be compressed and irritated? Many things. It could be a disc bulge, a disc herniation, a prolapse, an extrusion, a rupture, a herniated disc, degenerated disc, spurs, osteoarthritis, thickening of the surrounding ligaments. Many things could irritate the nerves. Now, how do you come up with the diagnosis of radiculopathy? That's one of the things that we're going to be focusing on in this presentation is how do you justify radiculopathy codes? How do you justify radiculopathy if you were ever questioned by an insurance company, a state board, or a malpractice case? Well, it begins with a very thorough history and examination. You want to ask a lot of questions with a patient that comes in and says, I have pain radiating down an arm or a leg. Everything changes in essence when you think about it. If, patient A comes in and says, I just have neck pain, that's it. I have full motor strength. I don't have any numbness or tingling down my arms, versus a patient coming in and saying, yeah, I have neck pain and it's radiating into my arm. I feel numbness. I feel heaviness. I feel tingling. And sometimes patients go, yeah, I feel that pain radiating down my arm. I thought I was having a heart attack. So your thinking cap has to be put on really tight to try and narrow it down. What is causing this patient's extremity pain? Most of the time it is nerve root compression, but I've had some patients come into my practice, and I'm sure many of you, can relate to this. It's not related to nerve root pain. There's other things going on. That's where you got to put on your diagnostic hat and really dig in. Now, in order for your services to be considered reasonable, justifiable, health insurance companies, your scope of practice laws require that your diagnoses have validity. They're compatible with your procedure codes. We're going to talk about that a little bit later. Pairing, like you pair food and wine. You should be pairing your diagnosis codes with your procedure codes. You wouldn't pair a spinal adjustment with an ankle pain diagnosis. The clinical rationale for choosing a diagnosis must be in writing, part of your care plan, entered into the patient chart notes. Now, after your history and exam, diagnostic testing may be indicated. Again, patient comes in just with low back pain, no other major symptoms, low back pain. Diagnostic test might not even take x-rays on a patient like that. Versus, here comes Mr. Jones. He's got low back pain. He's got pain radiating into his hip. He's got some numbness and tingling in his thigh. It's been going on for a while. He's had trauma here and there. He's been to other doctors. Nothing's helping. Probably time to order a diagnostic test. So there are many types of radiculopathy codes. Some with disc problems, some without disc problems. Some codes have disc problems without radiculopathy. Yes. Is that possible? Sure. It's not that common. Most patients that came in with MRIs that showed herniated discs, these patients did have radicular pain. They had something radiating down into an arm or a leg. But there are some patients that would come in and say, Dr. Kotler, I have low back pain. And that's one of the most common questions that are asked to patients with spinal pain is the pain radiating down an arm or a leg? It's a very common question that should be asked with any patient, any numbness, tingling into the extremities. Because once you have that, it's a sign something's going on and you got to dig in deeper. But every once in a while, a patient would come in with an MRI that shows a herniated disc in their neck, but they had no radicular symptoms. They had no pain, numbness, tingling down the arms. So that's a different type of diagnosis. I'll explain in a few minutes. Let's start off with some of the cervical radiculopathy codes. Here we go. These are cervical disc disorders with radiculopathy. So you might be saying, whoa, wait a second, Dr. Kotler, what's a disc disorder? Because there are disc disorder codes, there are disc displacement codes. So what's the difference between disc disorder, disc displacement? We'll get to that in a minute. But just take a look at the screen here. We have cervical disc disorders with radiculopathy. So when you see disc disorder with radiculopathy, you should be thinking, okay, this is a patient with some sort of disc pathology, some sort of disc issue. It could be bulge, a herniation, with nerve root compression, which is causing radicular pain. So let's take a look at the first one, M50.1, cervical disc disorder with radiculopathy. Okay, that sounds nice, but don't ever use that code. It's not specific enough. In the cervical spine, if you're going to use one of these diagnosis codes, you have to get level specific. So never use M50.1. Let's take a look at the next one, M50.10, cervical disc disorder with radiculopathy unspecified. I I wouldn't recommend using that. I would recommend you try and stay away from any codes that say unspecified in it. Unspecified typically means that your documentation cannot support a specific code. Why would you want to do that? So if a patient comes in and says, I have a herniated disc, and you don't know which level it is. The patient doesn't know which level it is. The patient, brought in an MRI and you didn't write down which level, then they took the MRI back, and now you have to report a diagnosis and you don't know which level? Yeah, you'd have to use M50.10. Try and stay away from that. And then we have M50.11. Okay, now we have specific levels. That's C2, C3, C3, C4. And then we have M50.12. That says cervical disc disorder with radiculopathy, mid-cervical. Again, too vague. Don't recommend it. It doesn't work. Most of the doctors using M50.12 are getting their claims rejected. Need to get specific. If it's at C4, C5, there's your 121. C5, C6, that's M50.122. If it's at C6, C7, M50.123. And then if it's at the cervical thoracic junction, if the herniation or disc disorder is occurring with radicular pain at C7, T1, that's M50.13. So these are the cervical disc codes. Now let's move on to disc disorder with radiculopathy in the thoracic region. Well, it doesn't get specific. Anywhere in the thoracic region, you'll use M51.14. We don't have one for T1, T2, T3, T4, T7, T10, T11. No. It's a little easier here. I thought on October 1st, you see, every year on October 1st, we get updated ICD-10 information. CPT codes and HCPCS codes, January 1st is the start date for the new codes. Now, this is November. I already have the CPT codes and the HCPCS codes that are going to become effective January 1st. They've been released. We're going to be doing a webinar in the next couple of weeks giving you the updates for the new codes that become effective, the CPT and HCPCS codes that become effective on January 1st, working on that. But as far as ICD-10 goes, October 1st of every year is when we get new codes. So I thought on October 1st of this year, we were going to get specific levels in the lumbar spine. So disc disorder with radiculopathy at L1, L2, L3, L4, well, it didn't happen. So M51.16 is for any lumbar level, and then L5S1, M51.17. Now we have another set of codes. You might be wondering, okay, so, what's the difference between, this cervical radiculopathy code, M54.12, for example, and the disc disorder? Well, the disc disorder with radiculopathy would require for you to have some sort of, MRI, CT scan. These do not. So let's take a look at these. M54.10, radiculopathy site unspecified. Ooh, don't recommend that one if possible. M5411, atlanto-occipital region. M54.12, yeah, that's a good one. Cervical radiculopathy, M5416, lumbar radiculopathy. Those are the most common, the .12 and the .16. So if you're creating a cheat sheet, a quick guide, whatever you want to call it, a favorite list, I wouldn't include M5410. Okay, so now I just want to get back to the difference between a disc disorder with radiculopathy and a disc displacement. See, I'm not getting into disc displacement codes too deeply in this presentation because disc displacement doesn't necessarily cause radicular pain or radicular symptoms. So if you take a look at this screen here, you'll see, let's take a look at cervical disc disorder with radiculopathy, M50.122. So that would be, Mr. Evans walks into your office. He's got neck pain and pain radiating down an arm. And it doesn't matter with the cervical disc disorder if the pain is radiating down the right side or left side. There's no laterality. Like with sciatica, you use certain, I'll show you in a few minutes, to designate right side or left side. With disc disorders and radiculopathy, it doesn't designate which side. Maybe next year on October 1st, we'll have that. So here comes the patient, Mr. Evans. He's got neck pain, pain radiating down his arm. He hands me his MRI. It shows herniated disc at C5, C6. I'm going to use M50.122. See it on your screen? Versus, okay, here comes Mrs. Wilson. Mrs. Wilson has neck pain. I'm going to ask her, do you have any pain, numbness, tingling, radiating into your arms? No, it's isolated neck pain, Dr. Kotler. And I have an MRI, and it shows that I have a herniated disc or bulge disc at C5, C6. Well, I'm going to go and use M50.222. So disc disorder with radiculopathy, disc displacement without nerve root compression. There's no radicular pain with the disc displacement codes. Here are a few more. Lumbar disc displacement without myelopathy. So common one there is M51.26. So this is a patient, again, that has some sort of disc pathology, but there's no nerve root compression and there's no myelopathy. That's another common question I get. And it's not embarrassing if you have a question, especially in this format. You're going to be kept anonymous. I'm just going to read the questions out loud and then answer them. But I have clients in practice 15, 20, 25 years that go, Marty, I feel embarrassed. I don't know what myelopathy is. So that's fine. I've collected a whole bunch of questions that I've been asked over the years. So just in case a client asks me, well, what's the difference between myofasciitis and myofascial pain? And what's the difference between spasm and contracture? And, here's one. What's the difference between radiculitis, radiculopathy, and myelopathy? Radiculitis, inflammation, radiculopathy, radiating pain, nerve root compression, and myelopathy is cord compression. So be careful if you ever diagnose a patient with myelopathy, you better have a CT scan or an MRI to back up the cord compression. It's very hard to know without a diagnostic test if the patient has cord compression or stenosis. Now, maybe with a herniated disc or a disc problem, many doctors say, well, I don't need an MRI to diagnose a disc condition. Okay, that's a clinical question. That's, up to you. I'm not going to challenge you on that. Next, sciatica. Okay, M54.3. Don't put that on your cheat sheet. M50.30. Don't put that on your quick code list. Too vague. Sciatica on the right, M5431. Sciatica on the left, M5432. Don't go searching for bilateral sciatica. That's another code I thought would have been created and added this past October 1st. But no. So if the patient has bilateral sciatica and you want to report both, then you'd have to report both. Then we have M54.4. That's low back pain with sciatica. This is a little combo code. If you remember back in the day with ICD-9, if the patient had low back pain and sciatica, we had to use 724.2 and 724.3. Those days are over. We have a combo code. Here we go, M54.4. That's low back pain with sciatica. Boo, don't use that one. Won't work. M5440, low back pain with sciatica unspecified. Hopefully you don't use that one. There we go, 41 right side, 42 left side. Now, as I mentioned, October 1st is the official day of every year where the new codes become effective. It was the same with ICD-9. Not sure why it's October 1st versus January 1st, like the other codes are. So this past October 1st, 2017, the updates came out. There were about 350 changes, 150 new codes, about 200 deletions. So I reviewed this list to see how these changes would affect the typical chiropractor in a typical chiropractic practice, guess what? I came up with very few. Most of the updates related to medical services, dermatology, surgery. So here's one. This may have been causing problems already in your practice. I've been getting calls just about every week. Doctors billing M48.06. Okay, that's lumbar stenosis. Pretty straightforward. But on October 1st, it got expanded to be more specific. So once codes become more specific, the rule is you always have to code to the highest degree of specificity. So if a code becomes more specific, you can't use the general one. So doctors, some of you listening to this, it may have happened to you already, where you billed M48.06, claim comes back denied from either the insurance company or your clearinghouse, but it doesn't tell you anything else. So you get confused. If you have a consultant like me that you can call, the problem gets fixed instantaneously. So here we go. M48.061 is lumbar stenosis without neurogenic claudication. M48.062 is lumbar stenosis with neurogenic claudication. So you have to choose one of those. Don't use M48.06 anymore. Even if you're using it and you're getting paid, I'm telling you, it's going to be a problem. Now, when I go over these two new codes, these are brand new codes, the M48061 and 062 as of October 1st. These codes are only a month old. When I go over these with my clients, the first thing I hear is, Marty, what's neurogenic claudication? So I thought I'd just give you the answers right there. Neurogenic arising from the nerve system, claudication meaning weakness or heaviness with walking. Neurogenic claudication results from compression of the nerves in the lumbar spine, also known as pseudoclaudication. Don't confuse that with intermittent claudication, which is vascular claudication. Sometimes it's referred to just as claudication, which is impaired blood flow to the leg muscles. Here's another item that I came across recently based on the hundreds of doctors that I work with. I get a lot of feedback. It's great information. My clients are doing a lot of work for me, in essence, where they're doing things, they give me feedback, and then I can tell all my other clients what's happening. So I have quite a few clients recently telling me, they're saying, Marty, I'm billing muscle spasm, M62.838. I bill it with myofascial pain or myalgia. It's coming back denied. Why is this happening? We call the insurance company. They can't tell us the answer. I call my state association. They can't tell me the answer. I'm calling all my friends. Nobody knows. One of those things, right? Very frustrating. This is where staff members listening, you could relate to this. You are trained to do things. You do everything that you're supposed to, and it's not working. Very frustrating. So let me give you a little tidbit here. When you're looking through ICD-10 codes, you're going to come across some codes that have an excludes one indicator. The excludes one indicates that two codes cannot be used at the same time, and the two conditions cannot be together. So if you use M62838, it has an excludes one indicator with myofascial pain syndrome. Just to hit this home a little bit further, ICD-10, justifying it. So let's say a patient comes in and you diagnose a patient with a sacroiliac sprain. Yeah, it's pretty common. SI joint subluxation, anything to do with the SI joint. SI joint sprain, sacroiliitis, SI joint hypermobility, SI joint subluxation. Okay, great. It's pretty common to have SI joint issues come into your practice. So you may diagnose sacroiliac sprain, S33.6. You submit that to the insurance company. Okay, now, if you're dealing with some of these managed care organizations, third-party administrators, you may get a call from the case reviewer. And they may say, hey, Dr. Kotler, we see that you diagnosed the patient with a sacroiliac joint sprain. Can you explain how you came up with that? You better have a good answer, or else it doesn't make you look professional. If you're involved in a malpractice case or a state board, even a cash patient can file a complaint against you. Actually, most of the doctors that I'm helping right now with state board issues, they're cash patients. So a cash patient can file a complaint. Now the state board is going to ask you for your notes, and you may get questioned. Or in a malpractice case, Dr. Kotler, how did you come up with this diagnosis of sacroiliac sprain? I could tell you when I first started practicing, when a patient came in with back pain and pain radiating down the leg, I just diagnosed sciatica. I didn't do any chiro test, ortho test, neuro tests. Patient has pain radiating into the leg. That's sciatica. Can't do that anymore. Those days are over. So, Dr. Kotler, you diagnosed the patient with sacroiliac joint sprain. Can you tell us how you came up with that? So here are the answers to that question. Well, the patient had pain in the SI joint, and sitting increases the pain. Lying down decreased the pain. And I also did Yeoman's, Ganslin's, so those are the gold standard tests for a sacroiliac joint problem. So if you're going to diagnose a patient with a sacroiliac joint issue, please do Yeoman's, Ganslin's. Now, I know I speak to some chiropractors. They go, Marty, I don't do any ortho neuro tests. I don't own a reflex hammer. I'm more of a straight subluxation-based chiropractor. I get it, and you can practice however you want. As long as you're helping patients, that's okay with me. That's my approach. But if you're ever questioned, if you're on the witness stand, doctor, how did you come up with this diagnosis? It's a good idea to do a couple of these ortho tests. Chiropractic findings show hypomobility of the SI joint, tenderness, edema. Here we go. Cervical radiculopathy. That's today's topic. So, Dr. Kotler, you diagnosed a patient with cervical radiculopathy. Can you explain how did you come up with that? Well, the patient had pain in the neck and radiating into an arm with some tingling. I did Jackson compression, did Sperling. Just do a couple. You don't have to do all of these. Do a couple of ortho, neuro, chiro tests. You do these tests, it'll help you SWAN. It's one of my favorite acronyms, SWAN. You know what that stands for? Sleep well at night. Do a couple of these tests, you'll be able to SWAN. I checked reflexes. There was some myotomal weakness. There was, the reflexes were normal, but there was limited motion and tenderness. You want to be able to come up with a clinical rationale for a diagnosis that you choose. If not, and you're questioned, you could be made to look silly. So, actually, this is an excerpt from a book that I highly recommend. It's the book on the best CPT codes and diagnosis codes to improve reimbursement. This is one page out of the book, and you see it. It gives you the diagnosis and then the ortho, neuro, chiro test to support it. So you see at the bottom, if you ever diagnose a patient with cervical brachial syndrome, Wright's, Atson's, now if you may be, out of chiropractic college for, 10, 15, 20 years, you might not remember how to do these tests. So simple nowadays. Go to YouTube, type in Wright's, Atson, Valsalva, any test, and all these little mini 1-2 minute videos will pop up, and it'll remind you how to do these tests. So this is a good little reference guide here. And I also recommend code pairing. So for every diagnosis code, you should have a CPT code. That makes sense. So cervical radiculopathy, that's pain from, radiating down the arm. Mechanical traction is one of the most common procedures that is recommended by insurance companies for cervical radiculopathy. Also for lumbar disc degeneration. If you have a patient that comes in with shoulder stiffness, wouldn't it be a good idea to do shoulder exercises to increase range of motion? There you go. You see, there's the pairing, like food and wine. Patient has fibromyalgia, bursitis, and you want to get in there and do some manual therapy to stretch the tissues, to reduce edema, to increase range of motion for your deep, soft tissue type work. Here we go, manual therapy. Pairs beautifully with fibromyalgia, herniated discs, bursitis. Alrighty, so just a few closing comments. Please check with all the carriers you bill prior to submitting claims. We can't guarantee that this information will guarantee payment from any insurance company or patient. Target coding is not responsible for any insurance carrier or managed care organization laws, rules, guidelines that may change following this presentation. And you know, they always change. So it's important to do your best to stay on top of these changes by attending seminars, webinars, joining your national and state professional associations. Here's our contact information. Oh, before we get to questions, this is the book that I was referring to. It's the book on the best chiropractic, ICD-10, and CPT codes to improve reimbursement. So this is the pairing, for example, therapeutic exercises. There are certain diagnosis codes that pair beautifully with therapeutic exercises. So this book provides them to you, broken down by region: cervical, thoracic, lumbar, extremities. There's also a section of the book that talks about long-term treatment diagnosis codes versus short-term treatment diagnosis codes, and we provide them to you. For example, sciatica will get paid for more visits than simple muscle strain. So we break those down for you, and we have our own little cheat sheets and quick guides that are in this book. And this is the page of the book that I showed you earlier that gives you the ortho, neuro, chiro tests for many of the most common diagnosis codes. And here's the frequently asked questions. Like, I've always wondered, what's the difference between effusion, swelling, and edema? And how do you objectively measure that? I see that in a lot of doctors' notes. Under the objective findings, edema in cervical region, edema at L2, edema at T10. How do you diagnose edema? What's the difference between cervical brachial and cervical radiculitis and idiopathic scoliosis versus thoracogenic scoliosis? What's the difference between myalgia, myositis, and myofasciitis? Oh, also, we recommend, strongly recommend now more than ever, is having a billing and coding playbook, a billing and coding manual, a billing and coding policy and procedure book. Just in case anybody comes knocking on your door, it's such a good thing to have. If your patient is, if you have a patient that's accusing you of, ripping them off, or your fees are out of control, you could easily remedy this by having policies and procedures. So why should you have a billing and coding policy manual? Well, for your staff, they want organization. Staff members listening to this, I know you want to work in an ethical and trustworthy atmosphere. Well, a billing and coding policy manual helps create a culture of compliance. It's an extension of your mission and values. And if you have a staff member that's accusing the business owner of wrongdoing, a policy manual can contain the ammunition to defend against any alleged misconduct. For insurance companies, a billing and coding manual can prevent audits, and if audited, it could mitigate fines and penalties. I'm working with a doctor right now. He's being asked back for $600,000 from an insurance company. I'm helping him put together a billing and coding policy manual right now. This is after the insurance company has already asked for the money back. We're putting it together. His attorney loved it. His attorney said that this is going to be one of the best things to use to help dramatically reduce the fines. And for the doctor, for you, the doctor listening to this, a billing and coding policy manual will help you swan, as I mentioned earlier, sleep well at night. It's a custom-made document for your particular type of practice. Like, what's your policy on full spine adjusting when you only bill for $98940? What's your policy on open therapy rooms? What's your policy on laser? What's your policy on timed codes? Now, if you see Medicare patient, it's mandatory. You don't have a choice, unfortunately. I like choices, but certain times you don't have a choice. Like if the speed limit is 70, I don't have a choice. I can't drive over 70 unless I'm willing to risk getting in trouble. So if you see Medicare patients, you don't have a choice. It's mandatory. You are required to have a Medicare compliance plan, which includes policies and procedures. So we put these together for clients. They're simple. They're easy to implement. You should have a policy on, well, Medicare requires you to do your own internal reviews. Every 4 to 6 months, you should be doing an internal review. We have our own chart audit tool. This is one of the best chart audit tools in the industry. I actually haven't seen one better than this. It really covers everything, and you could score yourself. It's basically an open book test where you score yourself. How great is that? Imagine, go back to chiropractic college when you were taking your neuroanatomy classes, and the teacher said, "It's an open book test. Here are the questions. It's an open book test, and you can score yourself." Don't you think most people are going to score an A? Yeah, so you're also required to go to the Medicare website, put your name in, and see if you've been excluded from the Medicare program. If not, print out the page, put it in your manual. This person, this is a nurse, cannot see Medicare patients, excluded from the Medicare program. Every person that works in your office, you should put their name into the exclusions list to see if it pops up. Yes, every person, not only the doctors. And we have another very important item here, areas of focus and possible compliance risks. We have a compliance calendar, cell phone use. Very important nowadays. A lot of my clients are saying, "Marty, I walk into the office, my staff is constantly on their cell phones. I don't know if it's work-related, personal-related." So I helped this doctor put together a policy on cell phone use. We also offer HIPAA compliance manuals. Very important. Again, it's mandatory. You don't have a choice. If you bill insurance companies or receive payment from insurance companies, you're automatically enrolled as a covered entity, and you must comply with federal HIPAA laws and regulations. And we also work with acupuncturists. We put together acupuncture billing and coding policy manuals with policies and procedures. We're going to be putting on acupuncture seminars in 2018. We also do seminars on many topics and webinars. Some are approved for CEUs. Again, here's our contact information. Thank you for attending. Let's go ahead and take a look and see what questions have come in.